Good afternoon, everyone. We have our annual session with our second-year students of the St. George's MBBS 4 course, which is the event where we have organized for them to speak to the public about rheumatic diseases. I'm Dr. Joseph, and I'm a rheumatologist, for anyone that doesn't know me, and I have the responsibility for this part of the year at the University of Nicosia Medical School. Today we have two talks, which will be 15 minutes each. It'll be hopefully quite a light session whereby Georgia Schmidt is going to talk about arthritis in general. What is arthritis? And it's important to say that these talks are aimed for the general public. They're not meant to be scientific talks, complicated terminology. They are, as we would like to understand it, all of us as people and as patients, rather than as we would find things in a medical textbook. And so Georgia will talk about arthritis, what is arthritis, and then Christopher Nicolaou will speak about systemic lupus erythematosus, or SLE, or lupus as we know it. Again, 15 minutes, and please bear in mind, everybody, that we will be able to have questions. If you go to the bottom, if you're on a laptop, it's the bottom right of your screen, and you can type questions in the Q&A section, so that when the talk, when the speaker finishes the talk, we can put your questions to them and they can answer. Please, if there are, which there obviously are, some medical students watching, do bear in mind that this is not a scientific talk whereby you're going to solve your queries about the esoterics of the conditions. This is for the public. So we want general, straightforward, logical, everyday questions that anyone would have about the conditions, and not about what do you see under the microscope or what is the molecular basis of things. You know what I mean. Without delaying us anymore, I will go on and give Georgia the floor to talk about the topic, what is arthritis?
Oh, sorry. Okay, hello everybody. My name is Georgia Schmidt. I'm a second-year medical student in the MBS program at UNIC. Today I'm going to talk to you about arthritis and all of its different types. Arthritis is a condition that I'm sure a few of you are familiar with, but you may not be aware that the term arthritis actually refers to over 100 different types. Arthritis impacts the joint, producing swelling, stiffness, and reduced movement. Depending on the type of arthritis, it can impact a single joint or multiple joints. Some arthritic conditions are common in older people, but others can actually impact younger people or children. Some conditions will be limited to the joint, but others will impact the whole body system. When we're talking about arthritis, there are two categories worth considering. The first being non-inflammatory. This type is caused by degeneration or wear and tear throughout the lifetime. The symptoms caused within this category can therefore be considered sort of a normal or a natural response to joint damage. The second category is inflammatory. These conditions are marked by an overactive immune response. So inflammation is the body's response to harmful stimuli. When we've damaged our joints, inflammation makes us aware that we've injured ourselves and prevents us from further injury as the body works to heal the damage. In inflammatory arthritis, the immune response is actually triggered inappropriately, potentially without any reason, and causes too much inflammation. This actually damages rather than protects the body. In this case, the inflammation is abnormal and unhelpful. So let's start by talking about non-inflammatory arthritis. The prototype condition under this heading is osteoarthritis. This is a type that's caused by normal wear and tear of the joints across one's lifetime. So given this, it typically affects people over the age of 60. The pain caused by osteoarthritis will increase throughout the day as the person loads their joints and moves their body, and so the pain will then lessen as they rest. It's important to note as well that osteoarthritis impacts everyone as they age to some degree, but it's just that it affects some people more significantly than others. Now that we've talked a little bit about osteoarthritis, let's talk about joints and how that will impact the joint. I just wanted to start by talking about a normal joint and drawing your attention to some key components. So the first in green, cartilage. Cartilage lines the end of the bones and will therefore protect bones as they move against each other. In pink, you've got the capsule, which is the outer layer of the joint. It holds the joint steady and stable and stops the bones from moving too far. In yellow, in the inner layer of the sort of capsule, you can see that what I've labeled as the membrane. It's often called the synovial membrane. This includes nerves and blood vessels and immune cells, and that acts to produce fluid, which is inside the joint and labeled here in blue. Fluid will lubricate the joint so that it can move freely. Now you're looking at a joint that's affected by osteoarthritis. Of note, the cartilage becomes quite thin. As someone sort of moves their body throughout their lifetime and puts stress on the joints, cartilage is broken down faster than the body can rebuild it. So eventually the cartilage becomes very thin and bones start to contact bone and cause irritation. That causes the bone to overgrow in an attempt to sort of protect itself, which you can see in red. Those bone spurs end up restricting movement and irritating the surrounding tissue. In pink, you can see that the capsule of the joint becomes quite thick and stretched, which makes the joint quite unstable. And then in yellow, lastly, your membrane becomes quite inflamed, and that leads to it creating extra fluid, which presents as pain and swelling for the person affected. Moving on now to inflammatory types of arthritis. Today I'm going to talk about 3 conditions that fall under this heading: rheumatoid arthritis, gout, and spondyloarthropathies. Starting first with rheumatoid arthritis, which some of you may have heard of. This condition is an autoimmune condition. So what that means is that the immune system, which protects our bodies against infection, has started to recognize the body's own cells or own tissue as foreign, which would mean it's a threat to the body. So in that case, the immune system will fight against these tissues or cells and destroy them. In rheumatoid arthritis, the condition rheumatoid arthritis is caused by genes that we inherit from our family members and environmental triggers which could bring it on. It typically affects joints on both sides of the body. So what that would mean is that if it affects the wrist, it's likely to affect the wrist on both sides of the body rather than just say one side, like other conditions. It commonly affects women and comes on in middle age, so 30 to 60-year-olds. Having a look now at a joint affected by rheumatoid arthritis, you can see that the membrane in yellow is very inflamed. So that will create hot, tender, and swollen joints for people affected by it. The capsule, which is the outer layer in pink, becomes really thick, and that contributes to joint stiffness, which is characteristic of this condition. And then lastly, all that extra inflammation, that unnecessary inflammation, starts to damage the bone, in which you can see in red, and that leads to joint deformity, which is basically a joint that looks abnormal from the outside and may not move in the same way that it used to. So as I've just said, rheumatoid arthritis is characterized by an inflamed membrane. That creates pain, stiffness in the morning when people wake up, and swelling of the joints. This pain will actually get better as the person starts to gently move throughout the day and kind of warm up their joints. But across people's lifetimes, the pain may escalate and settle in a flare-up pattern. So the symptoms may get worse for a number of weeks or months and then may settle, but the time frame can depend on the individual. This brings us to our next condition, which is gout. Gout is caused by excess uric acid. Uric acid is created when certain foods that we eat, such as red meat or seafood, or drinks like alcohol, are broken down in the body. Normally, uric acid is removed in our urine, but it can build up, and when that happens, uric acid crystals will deposit in the joint, like you can see in this picture. That triggers sudden onset severe pain. The pain will normally repeat in bouts where the pain escalates over 12 hours and reaches a high, and then it'll settle by itself after 10 days, even if you weren't treating it. Gout will typically affect one joint, most likely the big toe, but it can depend on the individual. Moving on now to spondyloarthropathies. This is a group of chronic inflammatory conditions which affect the spine and other joints. These diagnoses that fall under this category characteristically have lower back and buttock pain, but they also have some other symptoms like pain at tendons, so maybe at the heel, psoriasis, which is a skin condition, swollen fingers, inflammation of the eye, inflammation of the bowel, and changes to the nail. These conditions have quite strong genetic associations, so they can be passed down with certain genes and usually affect males under the age of 45. Now that we've talked about some conditions, I now just wanted to talk about how we can look after our joints to prevent some of these conditions. It's important to note, though, that some of the ones I've mentioned, like rheumatoid arthritis and spondyloarthropathies, cannot be prevented, given that they have genetic links. But we can always look after our joints and try and respond to things early to make things better in the long term. So the first thing to think about is seeking professional advice early when you get new joint pain, an injury, or posture. So in terms of injuries, if you sprain an ankle or you tweak a knee, some people tend not to seek help and will just deal with it on their own. But that can actually cause the ligament or injury not to heal properly, and that can put you at greater risk of osteoarthritis long term. The same goes for postural issues, so things like knock knees or pigeon-toed. People may want to seek support because that can put unnecessary stress on the joints and again contribute to osteoarthritis in the long term. Now that we know we need to seek support, I guess the next question is, who do we seek support from? So anytime you get symptoms, whether that's joint swelling or pain, the first step is to visit your general practitioner. From there, your general practitioner may refer you for specialist help, and it just depends on what type of arthritis you have. So if you have or you're suspected of having perhaps a non-inflammatory arthritis, which is osteoarthritis or conditions like that, these are caused when you have pain from joint damage. Those will be treated by the orthopedic surgeons. Whereas inflammatory arthritis, which is pain without joint damage or injury, such as like rheumatoid arthritis, these will be treated by a rheumatologist. However, your general practitioner will be able to refer you to the right people and make that process easy for you. Now that you're seeking help, the next thing to think about might be managing body weight. A healthy body weight puts less stress on our joints. Unhealthy weights can put you at greater risk of getting osteoarthritis earlier than other people. So if you're interested in managing your weight, you can contact your general practitioner or perhaps a nutritionist or exercise therapist for support with this. The next step is regular exercise. Low impact exercise improves your fitness and builds muscle. Strong muscles can support weak joints, so it's important to think about putting exercise in your routine. However, you don't want to do too much strenuous exercise before your body is ready, because that could of course make the situation worse. So next is footwear. It's important to wear well-fitting and supportive footwear to protect your joints. And if you need special support for that, you can always go to a podiatrist. Now that we've talked about preventing joint damage in the long term, I want to talk about what to do in the short term when you have joint pain. So as we've said, it's best not to ignore joint pain. You should rest as you need and take time off sports or work to recover if you need. Again, important to seek professional support as soon as you can. When you have a swollen leg or arm, it's important to elevate it to manage this swelling. So say you had a swollen ankle, you'd want to rest your ankle on some pillows as you sleep so that it's above your chest or your heart and the swelling can sort of subside as you sleep. Lastly, you might want to think about ice or heat, and it can be a little bit tricky to work out which one to use in which situation. But the general rule is that ice is for new pain or swelling because it numbs pain signals and settles new inflammation. But heat is for stiffness. It relaxes muscles and helps us move our joints more freely. Some people prefer to alternate those for different situations, but you could always seek more advice from this from a medical professional. So that brings me to the end of my presentation. I'd like to thank you guys, and we can do questions.
Thank you very much, Georgia. I think we can have questions from anyone who wants to ask Georgia for any clarification or anything they've always wanted to know about the general term arthritis. Anybody? Feel free to type in the chat room. Maybe I should start, Georgia, by asking you, people often say to us as rheumatologists, I haven't needed you yet, doctor. I'll need you when I'm old. And I won't say what I think when they say that to me or how I feel, but can you clarify what we should feel when people say that?
Yeah, so a rheumatologist sort of supports people with conditions that like exist across the lifespan. So there's arthritis in younger children, like juvenile arthritis, or as I discussed, rheumatoid can happen in younger people, or spondyloarthropathies as well, people under the age of 45. So yeah, I feel that phrase is false because people with these conditions should be coming to you earlier than older age.
And they're thinking of one particular arthritis only, aren't they, when they think of old age?
Yes, osteoarthritis, most likely.
Yeah, they're thinking of that wear and tear. Okay. Any questions, anybody? Feel free. However easy they are, straightforward.
Dr. Joseph, I can see a question. And I think you might need to help me with it.
Okay.
We have two questions, actually.
Maybe I can't see them because they're...
If you open the Q&A session, you can see it, Dr. Joseph. Otherwise, I can read it for both of you.
I can read it if you want.
Okay.
So there's a question about a person who is a new patient with rheumatoid arthritis, male, 58, and asking, when do you move from anti-inflammatory drugs to drugs that prevent long-term damage to joints in rheumatoid arthritis?
Okay, so I need to clarify what the question is because I didn't understand what those agents were.
In anti-inflammatory, I think is maybe what he means.
Okay.
Sorry.
Sorry, I've lost everyone completely. Can you still hear me?
Mm-hmm.
Well, I think, Georgia, you can answer the question of, when someone has a diagnosis of rheumatoid arthritis, and it's been officially diagnosed, yes?
Yes.
Do you treat them with anti-inflammatories?
No. So from my understanding, with rheumatoid arthritis, you have a window where you want to sort of start acting, and ideally you give them in that window, it's a 3-month window, you give them like what's called disease modifying drugs.
Exactly, which is the classic one.
What am I thinking? Methotrexate?
Yes, so methotrexate, for example, methotrexate is the classic one that you go for immediately as soon as there is the diagnosis. You don't say, okay, now is time to move from anti-inflammatories to long-term drugs. If it's an official diagnosis of rheumatoid arthritis and the symptoms are there, you want to avoid permanent joint damage, permanent inflammation, damage to other parts of the body even, by going to disease-modifying drugs. Okay.
Yes. And I think there's also another question that asks, can you differentiate between ligament or meniscus damage and arthritis? Which I feel, yes, the answer is yes, but you might just need to think about whether, like I guess in situations whether imaging might be needed to differentiate between the causes, and I guess the clinical relevance of that for the individual.
And the examination.
Sorry, what was, oh, and examination, yes.
Yeah, so arthritis will have, exactly like you say, Georgia, arthritis will have joint abnormalities. You may have swelling, there may be abnormality in the whole joint, there may be fluid. But if there is a meniscus damage, there are certain special tests that people do when they examine people's knees, for example, to see if it's a meniscal tear. And then the ligaments have got special tests on examination. And like Georgia said, if we are unclear, there are imaging things like MRI scans, for example, that will clarify.
Yes. Okay, so I've got a few more actually. So there's a question, is there a low-level over-the-counter painkiller that is safe to take if you feel arthritis pain? So I guess that depends on what type of arthritis the person has, because as we were just discussing, your kind of over-the-counter pain medication may not be what you need to be taking if you have like say rheumatoid arthritis. But in assuming this person has osteoarthritis, obviously in conjunction with their general practitioner, a person could look at taking what's called a NSAID, so a non-inflammatory medication like ibuprofen and things like that. But it might just depend on the individual what's safest for them. So I would recommend those discussions happen with a general practitioner.
What about before non-steroidal anti-inflammatories, Georgia? What simpler medication can people take over the counter?
Like Panadol or?
Yeah, so paracetamol. So there's no reason for someone to not start with paracetamol when they have a little bit of pain. Many people will say, oh, paracetamol doesn't help me. But you have to say that only after you've tried the proper dose of paracetamol, which is usually the 2 tablets 4 times a day, so that you see if it does what it should do for you. And exactly like Georgia said, you need to involve your doctor pretty quickly, because you cannot generalize and say that everyone can take this tablet or that tablet. You need to make sure that there is no contraindication towards taking it.
Yeah.
Okay, and your next?
Yes, so next one is if the joints start hurting after a long time of sitting, is this a sign to visit a doctor? So my immediate reaction to that would probably be, I guess it depends on what's normal for you and whether you're already seeing a doctor for certain conditions or similar symptoms. But I would suggest that it wouldn't hurt. So if it's something that is impacting you in your daily life, it might be worth going to a general practitioner just to see if they have any advice or whether it needs to be investigated, just to support you with that. Right? I think some sort of kind of discomfort after a long time of sitting is normal, but it just depends on, I guess, what you're experiencing and whether that's, you know, impacting your life.
Now someone says, so I can't see a specialist till August. Did you see that, Georgia?
Yeah, so that's the next question. So this is the same person as before about the disease modifying. So should I, he's asked, should I ask my general practitioner to prescribe disease modifying drugs now or wait?
Okay.
Yeah. You might need to help me with that one, Dr. Joseph. I would just imagine.
Yeah. Please give your opinion if you wish, or refer to me. It's whatever you like. You're doing very well with your answers.
You can correct me if I'm wrong, Dr. Joseph, but I would imagine that the best thing to do would be to go to your GP and discuss it with them and see what, I guess, their opinion is. From my limited background, I know that it's something that people like to start early, but I don't know whether that needs to be done in conjunction with a rheumatologist.
That's right, yes. You don't ask your GP to prescribe the drugs. You discuss what's going on, of course. We would like to believe that the system is such that you can see a rheumatologist quickly. So one needs to, if there is a definite diagnosis of rheumatoid arthritis, then it would be logical to try and see the rheumatologist as soon as possible. And of course, the GP can have access to a rheumatologist. They can discuss the case. They can do something in the meantime so that you can be comfortable and also you don't allow your joints to have any permanent damage.
Oh, Dr. Joseph, the person saying the earliest they can see a specialist on GESI is August.
Well, I don't want to get into political discussions because it's not the purpose of today's talk. The health system is wonderful in Cyprus in many respects, and it has its problems in other respects. So one way of doing it is to stress your urgency to your GP and do the best you can. Other ways are that there are people that are not in the health system, doctors, and they could help. I think you need to, unfortunately, the waiting lists are not something we can help with today.
Okay, and there's one last question, I think. So it's saying having twitching pain feeling in feet, I assume, after a physiotherapist's dry needling session. Is that something I should be worried about? Or perhaps should I seek support from a specialist? Okay, so I'm not really sure if that's something that's normal. I actually was a physiotherapist before this, but I can't say I did the extra training to do dry needling. So I'm not sure if that's something that's normal. I wonder whether it is something worth looking into, but I don't know if that's for me to say.
Yeah, I think that anything that you feel after physiotherapy for 1 day or 2 days or 3 days is acceptable to an extent, as long as it's not a worrying symptom. But I think if you have something that is continuing for many days or is troublesome or worrying, you just need to see your doctor. I think that's the most sensible thing.
Mm-hmm. Okay, and one last question. So I've heard about methotrexate resulting in quite a few negative side effects from friends who use them. what's normally done to make disease-modifying drugs more bearable for patients? To be honest, with my limited background, I know a little bit about disease-modifying drugs and the negative side effects, but I'm not sure if I have an answer coming to mind. So I might need Dr. Joseph help.
Yeah, we can deal with that. So basically, first of all, there are side effects that are avoidable with methotrexate by taking a folic acid tablet once a week on a different day to the methotrexate.
Of course.
The first thing is that you take your folic acid on a different day to the methotrexate, and it can help with the potential nausea, mouth ulcers, or other problems like that. I would say that although friends may stress that there are many negative effects from methotrexate, the truth is that a significant majority of people who take methotrexate don't feel very much in the way of side effects. You need your regular blood tests to make sure that it's safe. You need to be mentioning to your rheumatologists all the problems that you have, if you have anything. But I don't think it's fair to say that everyone says that taking methotrexate causes everyone a problem, because it doesn't. It causes some problems sometimes, and the folic acid minimizes these, plus certain other more specialized things that are done, but it's often very well tolerated. Is that it, Georgia, with questions?
Yeah, I think so. I think someone's just commented who asked a question earlier about the sitting and hurting, just saying the joints hurt after a long time of sitting and it becomes hard to walk on that joint for a period of time, which sounds like something worth looking into with a general practitioner.
Yep.
Yeah.
That's right. So thank you, Georgia, very much.
Thank you.
Thank you, and thank you to everyone for asking the questions. We're going to move swiftly on to Christopher, who's going to talk about, instead of us covering arthritis in general, he will talk about a specific condition, which is systemic lupus erythematosus, and that's going to be for the next 15 minutes.
Right. Can everyone hear me? Okay. All right, so good evening. I'm Christopher Nicolaou. I'm a TPO student at the St. George's program. And as Dr. Joseph said, I will be speaking about SLE, which I personally found very interesting, a case that we did do during this year. So to begin with, when speaking about SLE and autoimmune diseases in general, it is very important that we do understand the immune system itself. So I will briefly go through it, explain a few components of it before we move on to SLE. So as we know, the immune system is the defense system of the body. Okay, it defends the body against bacteria, it defends the body against viruses, it defends the body against parasites. Okay, it is an immune system that doesn't work correctly, or autoimmune disease, even diseases such as HIV and AIDS are incompatible with life. And this just illustrates how important the immune system is for defending us against any type of pathogen that does enter. The immune system is made up of two parts. It is made up of the specific part and the non-specific part. And this is mostly done, it's more of a medical separation of the two systems, but the two systems themselves work together to assist the body in defeating any type of pathogen. They're not completely two separate systems. They work they work integratedly a lot of the time. Okay, so I'm just going to move on now to speaking about the immune systems, the two parts of the immune system. The first one is the non-adaptive immune system. And as you can see, I've put here a cannon, and I've said here it acts like a wall and a cannon. And that's exactly what it is. The non-adaptive immune system is non-specific. It doesn't adapt to any type of pathogen that enters the body. So any type of bacteria, any type of virus. You can imagine it. You can imagine a cannon on the wall and a group of people running towards it. The cannon will fire and it will kill those people the same way every single time. And that's exactly how this the non-adaptive immune system works. Okay, it's got a broad response to any type of pathogens that enter the body. It develops in the womb. Okay, that's an important point because the non-adaptive immune, the adaptive immune system takes a while to mature in children. The non-adaptive part does not attack specific antigens or specific pathogens that enter the body. It's got a very blanket response. Okay, the response is rapid, so the non-adaptive immune system is the first line of defense in the body. Okay, it is made up of a number of components. I won't go into the details of that, but it's got chemical, physical, and cellular. Chemical, you can think of when the pathogen does come into the body and a non-adaptive cell finds it, it will release certain chemicals that will destroy that bacteria. Physical, your skin, your eyes, things like the gastric acid in the stomach all form part of the physical barriers that form part of the non-adaptive immune system. You then have very specific types of cellular response systems that form part of the non-adaptive immune system, and they are quite important. They are very important in linking the non-adaptive immune system with the adaptive immune system. All right. Now I want to speak quickly about the adaptive immune system. So as I said before, the non-adaptive immune system is very similar to a cannonball and to a wall. It is not selective. Okay, it is very blanketed. The adaptive immune system is very similar to this man here, which is, I've put here like a Navy SEALs. Okay, it is very selective, it is very powerful, it is very tactical. It's like guerrilla warfare. They will respond to only very specific pathogens that the body itself will alarm the adaptive immune system to, and then they will mount a response. Okay, so it will respond to red flags. What is a red flag? When a virus enters the body and enters the cells of the body, the cell will mount some sort of red flag on the outside of the cell to tell the adaptive immune system that there has been something that has entered that is abnormal. Or you'll have the non-adaptive immune system telling the adaptive immune system that something has entered in the body. They will then mount a very specific response to that specific pathogen. It's quite a complex system, but that's very briefly what it does. And we can think of it exactly in this way. Very tactical, very selective, and very powerful. Okay. Most of the diseases regarding autoimmunity, even the diseases such as HIV, are diseases of the adaptive immune system. Okay, so we can see how powerful this immune system is. Okay, this part of the immune system. All right, so I've put something in very quickly. All right, so you may wonder why an orchestra, I put aside an orchestra. I did used to be a conductor. And so I've compared the immune system with a symphony orchestra. Okay, a symphony orchestra needs to be tightly regulated. Okay, the conductor needs to know what's happening. The musicians need to know what's happening. If the trumpeter decides on the day of the concert he wants to go and play the violin, you will start having problems. And that's exactly the same with regards to the immune system. When the immune system decides to dysfunction, or for some reason is dysfunctional, you start having autoimmune disease. Okay, and what does this specifically mean? What happens is the immune system begins attacking the tissues of the body as if it is a pathogen that has entered. Okay, this causes a number of complications depending on how it attacks it, and there are a number of rheumatic diseases, autoimmune diseases that form part of this. Okay, so essentially the body forms antibodies against the tissues of the body, as I just said. It is not known why this happens. Often there is no real specific understanding of why, but it does tend to happen, and it's very similar to that idea. Okay. So now that I've spoken about the immune system specifically and how it needs to be regulated and the different types of the immune system, we can now move on to SLE. SLE is an autoimmune disease, and it is a very interesting disease because it is multi-systemic. Okay, it doesn't affect a single system; it affects quite a number of systems because of the nature of the disease, because of the way it actually because of the genesis of it, the start of it, the pathophysiology. Epidemiologically, meaning what type of populations it affects. And like a lot of autoimmune diseases, it tends to affect women who are in childbearing ages, a woman more, and more in the Black populations, okay? It has a variable presentation, meaning essentially that when the patient comes into the doctor's office, each patient may have a different set of symptoms compared to the next, which does make this disease very interesting, but can be quite challenging in terms of diagnosing and treating. Very characteristically, this is the most characteristic, is the formation of autoantibodies and immune complexes. Immune complexes essentially mean clumps of immune proteins that are insoluble in the body's fluids. They begin depositing in the vessels of the body. Okay. It's also polysymptomatic, meaning that there are a number of symptoms that occur. All right. What are the causes of the disease? Like many autoimmune diseases, we're not too sure. There isn't a specific cause. We aren't too sure why it occurs in the body. But there are a number of theories. The first one, as we know with a lot of diseases, genetics play quite a large role. Okay, we know this through twin studies that have been done, studies done with twins. There is a higher rate of SLE between twins. Environmental, we know that certain drugs can cause lupus. Pathophysiologically, meaning how is this disease, what causes the disease, how does it manifest? Essentially, normally in the cells of the body, the material within the cells is hidden away from the immune system. When viruses enter the cell or the cell gets old and it bursts, these proteins begin circulating in the blood, and in a normal person are normally taken away or normally extracted by the immune system. In people with SLE, for some reason, they circulate for longer periods of time, and the immune system sees them as a foreign pathogen because it's not used to seeing these proteins that are normally hidden away in the cells circulating, and then it mounts an immune response and then forms insoluble clumps. And these clumps then deposit within the vasculature of the body, meaning the vessels, the blood vessels of the body, causing the complications that we do know arise with this disease. The signs and symptoms, as I said to you, there are a lot of signs and symptoms that a person may present with. There isn't a specific set that distinguish one from the other, but we do tend to have a malar flush, which is what this photo here shows, and this is where the disease originally got its name from. Lupus, meaning wolf, is this rash that forms like a wolf bite on the face. You tend to have arthritis and arthralgia, photosensitivity towards light, oral ulcers, fatigue, weight loss, and very important to watch out for the patient and for the physician are kidney complications, because they do tend to become serious. You do have changes in blood, anemia essentially meaning a drop in the blood cells in the body. Again, that's because of an autoimmune response towards it. The immune system begins destroying these cells, psychosis, hallucinations, etc., and seizures. So those are the symptoms that a person may present with. There are a number of others. The American College of Rheumatology has got 11 criteria, and four of those need to be presented in order for a diagnosis of lupus to be made. All right, so what are the investigations? It is quite complicated, again, as I said, because of the presentations, the various presentations someone can come in with. The tests, the blood tests, and the clinical investigations are also not as direct, but there are certain things that a physician or a rheumatologist can test for in order to definitively diagnose for lupus. Urine analysis, meaning analysis of the urine, is very important, as I said, because of the disease, because of kidney complications. One needs to be mindful of that and do a urine analysis and check up on that. Again, as I said, you have the clinical presentation that someone comes in with, and the criteria that needs to be fulfilled in order to diagnose lupus. And then, as I said, a list of typical signs and symptoms. Okay, so the complications. It's important for the patient and for the physician to monitor this. It's also important to highlight that catching this disease early or presenting early to a doctor does obviously benefit the patient, and monitoring of these complications can be done. And in the end, you won't have this occurring. Often this occurs in more severe diseases or later down the line when someone presents. But the most serious complications are kidney. Okay, so one needs to watch out for this, essentially because the kidney is highly vascularized. It filters it filters all of the blood in the body, and often the immune complexes, as I spoke about earlier, begin depositing in the kidney, and the kidney then mounts its own response to this, and this causes the complications further down the road. You've got complications in the vessels of the brain and then vessels of the body, including the heart. Okay, because of the complications regarding the vessels, you have thrombosis, which is occlusion of the vessels, stroke because of the vessels in the brain, and then heart attacks, obviously, because of the vessels in the heart. As I said, you've got the complications in the kidney. It is the most significant complication to watch out for. It often presents with blood and protein in the urine, high blood pressure. The patient may present with high blood pressure. This is a complication of more the chronic kidney disease and fluid retention in the body. But the kidneys normally obviously excrete the fluid, and they are unable to do this in this complication. Treatment again depends on the severity of the disease and includes things like steroids, immunomodulators, and ACE inhibitors, and generally will be treated as chronic kidney disease. We then have neuropsychiatric lupus. I must emphasize this is quite rare. However, again, it is very important to watch out for. The American College of Rheumatology essentially says that if you cannot attribute the neural signs and symptoms to anything else except for the diagnosis of lupus, then it will be attributed to lupus. And things that a person might present with are a seizure, anxiety, psychosis, cerebrovascular, as I said earlier, leading to stroke and cognitive impairment. Treatments regarding this depend on the specific presentation that the person does come in. Again, it is quite rare. Other complications, as I said, thrombosis, occlusion of the vessels, decrease in blood cells, your anemias, and because of that, you'll have your infections, lung diseases, heart diseases, specifically relating to the vessels and the pleura, so the covering of both of these organs. Also, another complication to watch out for, because of the population it generally affects, difficulty conceiving and maintaining pregnancy. But this is not, again, monitored with a rheumatologist, monitored with a gynecologist, is something that can be overcome. Okay, so treatment. Treatment can be complicated, again, because of the variability of the disease, because of the different systems it affects. The treatment is complicated, but the goal is to induce remission, to change lifestyle, again, avoid smoking. UV light does exacerbate the rashes that people may present with. Important: exercise, relaxation, healthy diet, things like meditation, etc. Important to immunize patients, okay, because of the decrease in the immune system from the disease itself and because of the treatments that occur. It's important to immunize so they do not get secondary infections. Immunizing meaning vaccinations. Prognosis, very important to bear in mind that, and Dr. Joseph does tell us this, that the disease is manageable. Okay, in 95% of patients, the disease is manageable. They do have a good prognosis and can live mostly a normal life. Few patients present with severe end-stage disease or with severe complications. Okay, and with good care, they can be looked after. All right, so in conclusion, we now know what an autoimmune disease is. We know how the immune system works. It's not well understood how lupus occurs. It can be controlled. It seldomly presents severely. Kidneys are the most important things to watch out for. And most interestingly of all, most autoimmune diseases are now being linked to regulation of the gut microbiome and autoimmune disease and the immune system, and how the two link. All right, thank you very much for listening, and that brings me to the end of the presentations. I think I can take questions now.
Thank you, Christopher, very much. I think we can start with a question from Mr. Elena Stilianou, who says, can you please discuss discoid lupus as well, and how is it different from systemic lupus? You can always answer, and if you want, we can answer together like we always do. So please, that's your first question.
All right. Well, discoid lupus, essentially, I think I'm not too sure, to be honest with you. I don't have a direct answer, but I do think it affects more of the skin. They do present more with skin.
Discoid lupus refers to the skin. I think the important way that this should be phrased is, can you discuss skin lupus and how is it different from systemic? Discoid is a type of skin rash you find in lupus.
Yes.
But it can be in the systemic form as well. There are, however, in lupus, skin lupus and systemic lupus. And skin lupus is only in the skin, whereas systemic is the one that's got associated, potentially, involvement of other organs, and therefore needs the close monitoring, the treatment, etc. So lupus could be skin or general.
Okay. Any other questions at all?
I can ask you, Christopher, while everyone is getting ready.
All right.
It's amazingly common for our patients to ask us, is lupus a form of cancer?
It's definitely not a form of cancer. Completely two very different mechanisms and two very different types of diseases. It's got nothing to do with cancer at all.
Thank you.
Yeah.
And what about, what would you say to a 20 or 25-year-old woman who has a new diagnosis of lupus now?
I would say to her that overall the disease is fairly manageable, especially presenting at 25. She's still young. We can avoid the complications, and any type of complication that does arise can be treated and managed quite quickly, and that the prognosis isn't bad at all. And she can fall pregnant and have children, obviously with a little bit of more help and extra monitoring.
Very good.
Yeah.
Thank you. Any questions? Any more questions from anyone? Okay. Well, I would like to thank both our speakers. It's not an easy thing to speak in public, although this is, I dare say, it might be a bit easier to speak online. However, it's always an amazing experience for our speakers. I hope both of you agree. To talk to the public, to talk to people who want to hear about these conditions, and the very difficult thing to try and put it in simple terms rather than saying it all like you read it in your textbooks. After all, though, when you all qualify, you will be speaking in these terms to people, and that is part of the trick of being a good doctor, is making yourself understood when you speak to your patients. So this is a very good first practice for our students, and well done to Georgia and Christopher for doing this today. Thank you to everyone for attending. It is obviously might be important to you to hear, but it's also very important to our speakers to have the audience and this amazing experience for them. So thank you, everyone, and I wish you all a good weekend.